Assalamu alaikum wa rahmatullah. This is a fifth-year undergraduate dental student lecture entitled Treatment of Class 2. The material has been taken from the text Introduction to Orthodontics by Laura Michelle, 2013. At the end of this lecture, you will be able to recognize the features of Class 2, whether Division 1 or Division 2, and formulate a general treatment plan for a range of problems. Well, Class 2 has basically Class 2 molar relationship, but because of the effect of the anterior teeth on the whole general looking of the patient and the demand of treatment, we need to understand the incisal classification. And with the Class 2 malocclusion, the incisal has Class 2 Division 1, where the incisal edge of the lower incisors are posterior to the cingulum plateau of the upper. The overjet increase and the upper central usually proclined. There are several etiological factors, but generally skeletal, dental, and soft tissue have different implications in the general feature of Class 2 Division 1. For the skeletal classification, we can see Class 2 Division 1 in different skeletal relationship, but mainly in Class 2 skeletal pattern or sometimes in Class 1 skeletal pattern. And this is due to retrognathic of the mandible. Sometimes proclinations of upper incisor or retroclinations of lower is as a result of different severity of the underlying skeletal deformity. Regarding the vertical relationship, with a Class 2 Division 1, there are a range of vertical skeletal patterns, and the management depend on the severity, and it range from increase in the lower facial height, as in this case, to decrease in the lower facial height. The soft tissue in Class 2 Division 1 is mainly related to the underlying severity of the skeletal pattern. Sometimes, when the mandible is so retrognathic, the lower lip trap posterior to the upper incisors and cause further proclination. However, dental causes may range from crowding to spacing. Sometimes crowding happens, which results in teeth being pushed out of the dental arch, probably buccally, or sometimes the whole anterior segment will be pushed anteriorly, or spacing happens due to certain habits, like tongue thrusting associated with the Class 1, or sometimes digit sucking. In case of digit sucking, as we discussed that previously, it will cause a localized open bite, sometimes a new position of the tongue, producing adaptive tongue thrusting, squeezing of the upper jaw, resulting in cross bite, and retroclination of lower incisor, proclinations of upper incisor. And in this case, there will be exacerbation of the situation in Class 2 and make it more severe. There are different odontogenic features that can be seen in these cases. The most important one is the overjet. Overjet will be increased, and that's referred to incisor proclination, or sometimes protrusion, when the whole incisors being forward positions without change in inclinations with the Frankfurt line. Another feature is the open bite or deep bite, depending on the different features of underlying skeletal pattern, or even sometimes incomplete overbite can be seen in these cases. When there is lip incompetence, there will be some sort of gingival inflammations because of dryness. The molar relationship usually reflects the underlying skeletal pattern. The treatment planning in Class 2 Division 1, well, it's different from the early treatment to an adulthood. It depends on different factors, mainly the age of the patient, the severity and the difficulty of treatment, the patient's attitude and demand for treatment, and the stability as well as the facial appearance. It usually starts as early as possible when there's an increase in the overjet to reduce the risk of injury. But the most common age of treatment would be late mixed to early permanent dentition. We will talk about that later. Management of increased overjet is the prime treatment methodology or treatment targets for those patients. One of the treatment modality is by doing growth modifications. And this growth modification done by restraining the maxillary growth and enhancement of the mandibular growth. This can be done by lots of different devices. One of them is what we called the headgear with a horizontal, vertical pull depend on the directions of the growth modification. The other, definitely you know it, which is the functional appliances, which may range from simple upper removal appliance with anterior bite plane that cause the mandible to slip and slide forward to more complicated appliances like the Bionator or Frankel appliance or Endresen appliance. This appliance is so important and it has a very good advantages, especially if the patient is captured in a very good age, like for example during the growth spurt. There are lots of dilemma whether to use the growth modification before fixed appliance or using the fixed appliance with growth modifiers. And sometimes capturing the patients in proper age, you can do the removal appliance, enhance the growth of the mandible, and then after gaining the benefit from bony growth, we can jump to fixed appliance. So there will be a phase 2 treatment, which is the next type of treatment. The second line of treatment is the orthodontic camouflage by using fixed or sometimes removable orthodontic appliance, but in complicated cases we need to use a different force system with different torque, and this can be done by using fixed appliances. The fixed appliance sometimes can be incorporated with the fixed functional appliances, and this is important in order to decrease the time of treatment. As I told you before, the line of treatment would be typically having my functional appliance as phase 1 and then the orthodontic camouflage by fixed appliances. But sometimes people would prefer to use one treatment phase by fixed appliance with fixed functional appliance. Well, gummy smile basically associated with increased vertical skeletal proportion, especially the anterior maxilla, and or with short lip or sometimes hyperactive upper lip. The prevalence of gummy smile in our country is high and especially associated with the class 2 cases. The treatment, well, there are lots of lines of treatment. However, the most now commonly used is using temporary encouraged devices with titanium springs or sometimes elastic thread. The final line of treatment would be surgical correction, and that happens when the case is so severe that camouflage treatment wouldn't solve the problem or maybe cause complications by being the roots outside of the supporting tissue. And here, for example, The treatment would be by some sort of bilateral sagittal split for the lower jaw and default one for upper jaw, sometimes only attacking the upper jaw with intrusion in cases of deep bite or excessive maxillary excess. Well, it's very important to think about retention. The retention should be directed toward achievement of lip competence and decreasing the overjet. Otherwise, the lip would be definitely trapped between the incisors and cause continuous pressure on the upper, and so increasing the overjet and increase the relapse risk.